Over to you, Jenny, for introductions.
Perfect. Thanks so much, Tanya. Well, hello, everyone. Good morning, good afternoon, and good evening to all those joining around the globe. My name is Jenny Green. I'm based in Phoenix, Arizona, and I am the lead behavioral scientist that is helping to manage the Resilience Collaborative. I've taken over for Sarah Mullane, who she has recently transitioned to a new role as the health technology lead within the GCI organization at Johnson & Johnson. So if you start seeing more communications for me instead of Sarah, that is why. She's still here, but she's just moved on to a different role. If you haven't already, please take a moment to share in the chat your name, where you're calling in from, and even your organization and or professional role. Would love to see where everyone's calling in from. Like we said, the session is going to be recorded, and we'll be sure to share that out after the session. I would like to now take this time to thank you all for joining this exciting webinar, where you will hear from several organizations and their experiences in the working group that was focused on adapting the Resilience Message program using human-centered design principles. And also thank you to our speakers today, who I will introduce in just a moment. They are all part of incredible organizations doing impactful work, and we are really looking forward to hearing these exciting learnings. I will just briefly introduce our speakers, and during their respective talks, they'll give you a little bit more information about their organization and what they do. So first we have Tanya Kapoor. She is a project manager at Dimagi. She co-facilitated the working group for health worker resilience and is overseeing the pilot implementations of the Resilience Message program. We have Liliana Bagnoli, and she's the Deputy Delivery Lead and Mental Health Lead for Dimagi's India division. Job Anuche Itanye is a nutritionist for Africa Youth Growth Foundation. Jafar Lawal is a monitoring and evaluation officer for Africa Youth Growth Foundation. Dr. Paulo Borum is a senior director at the Institute for Healthcare Improvement. Cristiana Gomez is a faculty member at the Institute for Healthcare Improvement. Angel Bienvenu Ishimwe is the Director of Behavior Change for TIP Global Health. And Celine Uwingabwe is the Director of Quality Improvement at TIP Global Health. So a warm welcome to our speakers today. Before I hand it over, I do just want to note a few housekeeping items. So first, just please be sure to keep your microphones on mute so we avoid some background noise. However, if anyone in the audience has questions during the presentations, feel free to unmute yourself and ask the question, or just add it to the chat. We have also designated time at the end for Q&A as well. And like I said, the presentation will be recorded, so we'll be sure to circulate that at the end as well. And with that, I will hand it off to our first speaker, Tanya. And I think you're on mute.
Yes. Thanks, Jenny, for the introduction and also for setting the context for the day. Welcome, everyone. We're really excited to present to you our learnings from the working group that Dimagi hosted with support from Johnson & Johnson's Foundation for Health Worker Innovation. Without further ado, let's get started with the agenda for the day. For this session, we will be starting off with providing you with an overview of the working group, the objectives of the working group, and how these sessions were structured. We will then hand this over to representatives from 3 organizations: Africa Youth Growth Foundation, Institute for Healthcare Improvement, and TIP Global Health, who will be sharing an overview of the work that their organizations are doing and their learnings from the working group sessions. We are really grateful for all the participants and are looking forward to hearing their insights from the working group. Just as Jenny mentioned, we do have a Q&A block towards the end of the sessions. We encourage you to save your questions for this Q&A block. However, as the speakers are going through their presentations, if in case you have any questions, please feel free to put them on the Zoom chat. We will save them until the Q&A and make sure that our presenters have as much time as possible for their presentations. Awesome. So let's get started. So Dimagi hosted a working group from March to May 2022 with support from Johnson & Johnson's Foundation for Health Worker Innovation. I will now refer to them going forward as the center. Over the course of the 3 months, 6 organizations from different geographies like Brazil, Nigeria, Rwanda, Uganda, and Mexico participated in a series of 6 sessions. These 6 organizations included Dimagi, along with Institute for Healthcare Improvement, TIP Global Health, Africa Youth Growth Foundation, Living Goods, and Partners in Health. These organizations engaged in a collaborative process of adapting, localizing, translating the center's resilience message program for health workers using human-centered design principles. As part of the working group sessions, Dimagi wanted to draw on our company's 20 years of experience of adapting mobile job aid tools for health workers using human-centered design process. The purpose of this working group was to provide organizations with a roadmap that they could follow to adapt and localize the messages from the resilience message program to ensure that these messages resonate with the health workers belonging to a specific geographic as well as linguistic setting. For the working group, we had 3 core objectives. Our first objective was to provide the participants with an understanding of the resilience message program and the underlying themes that the content covers. The introductory session of this working group took the participants through an overview of the evidence-based resilience building behaviors that these messages are centered around. The next core objective was to provide a set of key considerations that organizations should follow while adapting and translating the messages to ensure that they are more relevant, usable, and acceptable to health workers from their respective geographies. This was foundational and one of the core components of the adaptation process. There were several parameters that we started thinking about. The first parameter was how to select a persona for the messages. In other words, this required us to think about who the audience will think these messages are coming from, whether they would come from a supervisor, whether they would come from a trusted friend or a colleague or a government official. The second parameter that we started to think about is how to select a relevant voice and tone for our messages. In other words, how will the audience feel based on the way these messages are communicated? Would we use humor to convey these messages, whether we will be using a formal or an informal tone? We also discussed how these organizations can help identify terminologies from the resilience message program that might be new or not commonly used by the health workers. For example, what should organizations do if a specific word, for example, resilience, can't be translated directly to a target language? We also learned how we can make these messages more relevant to the health workers by adding examples from their day-to-day lives. We also discussed best practices around how to translate this content so that the language is well understood by our audience. The final objective of this working group was to learn how to validate the messages that we have adapted with the target audience to ensure that they are more usable as well as acceptable to the health workers. The implementers followed an iterative user testing process where they conducted multiple rounds of user testing that allowed them to make incremental as well as user responsive changes to the content based on the insights and the feedback from the health workers. Now let's talk about how this working group was structured. The working group was a series of 6 sessions that took place over 3 months. During each sessions, the organizations engaged in sharing circle. Sharing circle was basically a collaborative space for our organizations to share their learnings and insights from the adaptation and testing process. As a follow-up to each session, organizations worked on post-session activities such as reading relevant resources, as well as conducting user testing. We also created a shared folder that included all the important and relevant resources that would support these organizations as they adapt and translate their messages. As an outcome of this working group, Dimagi is also working on creating a guidebook on content adaptation that outlines a process for organizations who are looking to adapt, translate, localize, and test these messages from English into a target language. Each organization spent approximately 15 hours a month, which included attending the sessions as well as working on the post-session activities. At the end of the session, the organizations were encouraged to share their feedback on the working group, share the set of adapted messages, and their learnings with the members of the Resilience Collaborative community. Now, talking about our takeaways from facilitating a working group, we understood that there is immense value in hosting collaborative learning spaces where the organizations can come together for exploration process. Bringing together organizations with similar goals and challenges creates a platform for collaboration, both during and after the working group. For these working group sessions, it was critical to have a dedicated facilitator and a co-facilitator who could moderate these sessions, manage the logistics for the working group, which included scheduling invites, sharing resources, and providing support in between the sessions. Talking about our reflections from the working group, if we could do this again, we would make sure that we are providing a space for the organizations to share more about their individual context, possibly by creating a rotating partner spotlight session that allows each organization to present their overview during the working group sessions. We would also encourage participants to pair up and collaborate as they work together on post-session activities in between the working group meetings. We would also invite participants to facilitate specific parts of the session, for example, the sharing circle, which could be moderated by different participants during each meeting. This was an overview of the working group session. I will now hand this over to Joe from AYGF, who will be walking us through the work that AYGF is doing and share their reflections from the working group. Over to you, Joe. Hi, Joe. Were you able to hear me?
Okay, can you hear me now?
Yes, we can hear you. Go ahead.
All right, great. Thank you. Thank you, Tanya, for that elaborate introduction, and welcome everyone to this presentation today. It's such an honor to be part of this. My name is Onuche Itanyi Job. I represent one of the organizations that participated in the working group session and collaborating with Dimagi and Johnson & Johnson on this project. I am a nutritionist, a nutrition specialist on the ARIN World Bank funded program. Currently, we're implementing in Niger State in Nigeria, West Africa. And I have also my colleague, Ms. Jafar, also with us, had gone through the session. So let me not bore you with some of the detailed introduction, but let me go quickly to my presentation for today. Like I said, I represent the African Youth Growth Foundation. This is an organization that is community friendly and founded in 2003 and officially incorporated in 2006. We have a corporate affair headquarters in Abuja. We're also implementing in 2 states of Niger and then Kogi State. We're partnered with several countries like Britain, Colombia, Canada, and then currently in Nigeria. Next slide. These are working partners in the course of our journey as a non-state actors and also an NGO. We have been able to partner with these various esteemed groups and then organizations like EU, UNDP, UNICEF. And like I said earlier, we're currently implementing the World Bank ARIN. ARIN is an acronym for Accelerating Nutrition Result in Nigeria. and then we are implementing in Niger and then Kogi. Next slide. All right, as an organization, we have 7 thematic areas that we operate in. We have migration, public health, education, demographic governance, climate change, violence, extremism, and then livelihood. But for the purpose of this, I will quickly just want public health, which is a core area where we are at this point. Next slide. Well, this is just to show you where we operate from, the state office in Niger. Nigeria. Next slide. And this is also same as what I've actually explained before. These are state office. So we have a well-functional office to operate from. Next slide, please. Thank you. All right, AYGF got a link to participate in this important program, which has to do with the well-being of frontline health workers, since we are currently also utilizing this particular set of individuals, we thought it as important to be part of this. So participating in the working group, next slide. Well, we had, like Tanya explained earlier, we had a working group section that spanned from over 4 months or so, sorry, and we had different activities that we participated in, and these are some of the key takeaways from the working group. First is that the true meaning of resilience was localized and understood. The appropriate voice tone fit to deliver the message to our own health worker was identified. We're able to do that. The right and appropriate translation for message delivery to the health workers was also identified. Then we have various challenges faced by community health workers were also known based on our interaction with the health workers in the course of the working group. And the health workers are really enthusiastic about the Resilient Message program and are ready to scale up if given the opportunity. And also that the session gave each member of the working group an opportunity to bond and to get to know each other. So these are some of the key takeaways. Next slide. Then the session was also a capacity building avenue for members of the working group. The recording session helped a lot and because at times, due to one challenge or the other, we might not have maybe network or so, we don't get the content well. When you go back and listen, you'll be able to digest and localize the message. Also, that the opportunity for physical pilot is also given. So these are, next slide, these are the key takeaways from the working groups. Yes, during the course of the working group, we had health workers selected, and then we had to brief them about the program that we're about to commence, and then the importance. So this picture depicts when some of these health workers visited us in the office. We facilitated their movement down to the office, and then you could see Mr. Jafar and then myself at the background talking to the health workers that we intend to use. Next slide. All right, okay, this is also myself during one of the sessions we had with the head worker. Next slide. Okay, as part of the requirement for the Resilient Message program, we had to do user testing on the health workers that were selected. So this picture is showing at the point where we had to visit them in their facility and then also facilitating the user testing. This is during some of the rounds. Next slides. Yes, this picture is also showing some of the user testing rounds and sessions that we have with the health worker. Next slide. All right, the proposed pilots. Next slide. For this pilot study that we are about to commence, there are certain deliverables that is expected of us. One is that we must adapt the content of the message and translate to the appropriate tone. Generally classified under content adaptation. Then we had a baseline survey, which we are about to commence. We have expected of us is also the baseline reports, the pilot program itself, midline survey, you have the midline reports, endline survey, final report, and then publication at the end of the pilot phase. Next slide. Now, as an organization participating in this, we have several implementation strategies. We plan to, of course, we have already done that, select 20 health workers per, that's 2 per facility in 10 wards, meaning about 10 health workers per facility. And they will conduct physical training of health workers before the pilots commence, and then enroll health workers on the WhatsApp platform for easy communication and feedback. We'll have monthly supervision conducted and follow up to build gap and schedule interview sessions. This is some of the implementation strategy we intend to use. Next slide. Also, as part of our implementation strategy, we'll have to do very critical advocacy, which is very relevant in this part of the country. We'll have to carry along some of the state ministry health departments, maybe conduct advocacy to the Director of National Primary Healthcare Development Agency, and then the officer in charge of each of the facilities that we intend to use. We need to carry them along, else they can, the program might be frustrated. So that's one of our strategies. Next slide. Well, for message content adaptation, we have chosen to use this particular, where we chose to use the serious, casual, and respectful and matter of fact, which is one of the key content adaptation strategy. And then we also, based on our feedback from the health workers, then we also have our languages will be in English, although simplified into languages, simple English in Nigeria where people can understand the concept of resilience. Then we also have to replace some tricky concepts that we found in the message, resilient messages, and so as to suit the culture of the people here. We also have to add examples to facilitate the understanding of the community health workers that will be carry out this pilot with. Next slide, sorry. Well, we expect to use as our data outputs explorative. We have to also use comparative in line with what we have chosen as our implementation strategy. Next slides. Well, in programs like this, and from our experience, we know there are challenges, and some of the challenges are here, are listed here. We have security, we might have dropout of community health worker, and then also more interest from other community health workers, because part of what we discovered was that some of the health workers that were not selected, others were much interested, and then we have to find a way to see how, and this is a challenge, and that we must find a way to mitigate. Then inflation, of course, is also another challenge. Next slide. Okay. I think that's all. Thank you. Thank you very much.
Thanks, Joe, for sharing these insights. These were really interesting, and we are looking forward to hearing more from AYGF as well as our participants during the Q&A section. Our next organization is Institute for Healthcare Improvement, and I would now like to invite Paulo to start us off.
So good morning, good afternoon, good night. My name is Paulo Borém. I was born in Brazil, but I live in the US right now, in Houston, Texas. And I'm the Senior Director of IHI. And my work is mostly in the Portuguese-speaking countries like Brazil, Portugal, in Mozambique. So let me speak a little bit about IHI, the Institute for Healthcare Improvement. IHI now turns 30, it's 30 years old, and was created by this physician that you see in the picture, that is Don Berwick. And the idea of the creation of the Institute for Healthcare Improvement was this idea that we could use the improving methods that Toyota, NASA, and other organizations use to produce or offer service without any defect. Could you translate these improvement methods to the healthcare system to offer a healthcare system without defect to patients and families? And so with this in mind, IHI was created, and we translated all the work from Deming, Juran, Schuher, to the healthcare system. So IHI is a nonprofit organization with the headquarters in Boston, but it's a global organization. And our mission is to improve health and healthcare worldwide. Next, please. In our vision, everyone has the best care in health possible. And this is one picture from a collaborative in Brazil to reduce healthcare hospital-acquired infection in half in 200 public ICUs. We worked with this team for 3 years, and yes, we could help them to reduce hospital-acquired infection in more than half in all the 200 ICUs. Next. So IHI values are love, courage, equity, and trust. And IHI is very interested in this topic of resilience. And it was a great thing that happened to us was to meet Johnson & Johnson and be part of the Resilience Collaborative. Because 3 or 4 years ago, IHI published a white paper, which name was Joy in Work and Resilience. And then we got acquainted with Johnson & Johnson work in resilience. And we thought that it was a great combination of efforts between J&J and IHI. And now we incorporated the resilience aspect of being something personal, because IHI was working with the concept of resilience to be part of the system, but Johnson & Johnson also was working the resilience as a personal trait or a personal journey. So this combination is perfect, and we are very happy to be here. And everything that Chris is going to show here is going to be applied to more than 100 hospitals, public hospitals in Brazil. We are very excited, and I think next slide, please. I think now I'm going to transition to Chris. Just to say that everything that we did was translated to Portuguese. That's the language that we speak in Brazil. And our white paper around joint work is we have the version in Portuguese and also in English, and it's a big reference to us. Next. So before I transition to Chris, I want to just say that the joint work framework has nine pillars, 9 big buckets, let's say that way, and resilience is one of them. So when we propose to our organization to start this journey around resilience in joint work, we start with management, participative management, and then we transition to safety psychology, physical safety, meaning, in purpose, etc. So in this, all this work is being incorporated to our big framework that I briefly mentioned here. Next. So I think I'm not going to spend time in this slide. I mean, just next, please. I'm just going to say that we working with this concept that resilience, it has a personal aspect, but also has a system aspect. And we are combining both to work with these 100 hospitals, and the messages are going to be part of this big intervention to improve joint work and resilience in 100 public hospitals in Brazil. Next. Next. So the methodologies that we've been using, the first step is ask the workers what matters to them. And we asked them to put some post-its on a board. And then the next step is we identified what is important to them. And then we asked them, what are the impediments to have resilience and joy in work in the work environment? And after we create the categories of these impediments and what matters to them, we ask them to create working groups to solve the problems, to remove the barriers, to create a resilience system, and to improve their personal resilience. And then the fourth step is to use the model for improvement, running small cycles of change. Let's say, for example, if they're not happy because the coffee is always cold. So we asked them to create a group to solve the problem with the canteen, the food, or whatever they want to work on. So, but they really use the model for improvement, the improvement science, to run small tests of change, to test, see what works, and then they implement in the whole organization. And the next step is spread these in all units in the organization. Next. So we created what we call a theory of change. That's the driver diagram. In this driver diagram describes the aim on the left, and in the primary drivers, what do we have to do to achieve this aim? And then we listed some change that the unit has to do to achieve the aim. Next. So keep going because it has the aim, what to do, and how to do it. Okay, next. So I think I'm not gonna spend more time on this because it's just I'm just describing the four phases of the work. What matters to you, impediments in resilience in joint work, and then the creation of the working groups to solve those problems, to remove the barriers, and finally sharing and spreading all over the organization. Next. So Chris, now I'm gonna ask you to describe the test that we did with one hospital in adapting and translating the messages. Chris, go ahead with you.
Thank you, Paulo. Hi, everyone. I'm Cristiana Gomes. I'm an infectious disease physician, and I'm working as a IHI faculty in Brazil in projects since, I think, 4 years now. So I bring it here to you some of our key takeaways about this process of translating the messages. Our group of interviewers, our team, our working group to do this work came together a little bit late in the process, but we have a very strong group now. We have Maria Magalhães, which is a psychiatrist, me and Paulo. Mario Rodrigues is a psychologist, and Teresa is an improvement specialist also. So we did this, user testing and adaptation of the messages with a hospital located in Maranhão. It's a state in the northeast of Brazil. And that hospital was one of the participants of the Reconectar, this work that Paulo just showed before. So we had 4 healthcare workers that permitted to be part of the process and the test, which were, one was an occupational therapist, a phonologist, and 2 nurses. They took part in this work where 2 meetings were, the meetings were by internet. We were in different states and different countries. So this was how we managed to do it. Next, please. And how did we do it? First of all, we choose the tones. We translated our group 3 of the message, the speech pathologist. Thank you, Paulo, very much. We translated 3 of the messages in the 3 tones and voices. So the users, since we have a language barrier, it wasn't possible just to choose from the English. So we translated to Portuguese in the different tones, 3 different tones and voices. And we read one by one to the group to see which one they thought was the best. So they choose the preferred tone. It was interesting because everyone choose the same one. We'll talk about it later. So it was interesting to notice the tone serious, casual, respectful, and enthusiastic was the preferred for all of everybody involved in the work unanimously. And they mentioned that the Brazilian culture is informal and it's important. The language is a way to approach in a place now where we have, especially healthcare environment, there is a high hierarchy gap. So language it's a differential to be close and trusted in this relationship with the healthcare workers, leaders and healthcare workers. So, and also the learnings, it was a consensus. We assumed that this would be the tone. And so we move on to the translations of the message in the chosen tone. Next, please. How did we do it? So we translate, this is an example, we translated a message in the preferred tone and voice, and we read it to them, and we ask explorative questions that were, who did you think this message was coming from? Would that message make you act, and why? What did you understand about the message? Was there a word or concept that made your understanding difficult? Which was it? And by reading the message, how did you feel? And do you think you'd have a better way to write the message so the next person would understand it better? And the suggestion. So this is how we did. Next, please. What we learned in doing this. So even with the casual tone, the informal one, they had the feeling that the message was coming from someone who really knows what they were speaking about, like an expert in the subject. The introductory message made them very curious about the program with expectations. Also, simple and direct language they prefer this much better for understanding. So cumulets and pronouns and articles, so very simple writing. And also they had the feeling, I think this is the word they said, that the messages had a positive impact. Next, please. Also, there were some messages that use the imperative verb, and the feeling they had is that it seems like an order. So culturally, they understood that changing this verb would be more polite, less arrogant. And also there were some jargons, some sentences that did not translate exactly to the group. One example is one of the messages, message 6 said, it's not the load that breaks you, it's the way you carry it. And so they reflect a lot about what that means. And they got to the final translation is, you can lighten the weight of the load by modifying the way you carry it. So some small adaptations in how it went. Next. So we did this for the first 10 messages. As I said, our group came together about 5 weeks ago, and the group the users now also we start talking to them about 4 weeks ago. And with these insights, the next steps to finish the translations before the pilot study is going 20 by 20, getting this knowledge that we get and sending them to the Maranhão, the healthcare workers from this hospital, and they will send us back with their input and feedbacks. I think that's the last one.
Awesome. Great. Thanks, Chris, for these insights. It was really exciting to learn about IHI's theory of change, as well as the organization's insights on the complex terminologies and how the team adapted those for testing purposes. I would now like to invite Angel from TIP Global Health to walk us through their reflections from the working group sessions. Over to you, Angel.
Thank you, Tanya. I hope I'm audible. My name is Angela Bienvenue Ishimwe. I'm from Rwanda, working from TIP Global Health. I'm a director of behavior change, and I'm joined by Sarine Oingabiye, who is also a director of quality care. And we have tested the resilience messages with the guidance from Dimagi and the resilience working group. So I'm happy to share what we've done and the lesson that we get from that journey. Next, please. Allow me to introduce you to Global Health. Our mission is to achieve lasting improvement in a health outcome in resource-limited settings. We are currently working in Rwanda, in different districts of Rwanda, in rural area, peri-urban area, and even urban areas, where we are mainly creating or co-designing solutions alongside with healthcare workers. And we are promoting those innovations to the Ministry of Health, especially to see how we could change the health system in Rwanda and where we could be moving our work in. So our vision is a world in which quality healthcare leads to inclusive, empowered, and health system community. Next, please. With this, we want to really see our healthcare system changing from what it has been used to be. It used to be where a health recipient or a patient feels that they are sick, and then they go to seek for the care to the health facility. And then when they get there, they can meet a healthcare provider who is overwhelmed, and they can receive one-time service, probably poor quality care, and then they go home and never come back. Now, with this transformation, we would like to see a healthcare system where a patient is accessing care, receiving a quality care, and then go home, adopt the care recommendation, and then continue this this cycle, like continue the relationship, continue to seek the care, or creating a good, strong relationship with the care provider. That will allow the health system to be a prevention of disease, the early diagnosis of disease, early treatment of disease, and then continuity of care, which would be possible when there is a strong relationship between a healthcare worker and the patient that they are serving. Next, please. So that to be possible, there are many challenges, and TIP Global Health is providing possible solutions to that. And what one of the solutions that we are providing is to see how hope can increase or can be an antidote to many challenges that quality care is facing. Hope that is defined in these three factors: interconnectedness, readiness for change, and future mindset, is also one important key, especially about interconnectedness, that could foster a relationship between a mother or a healthcare provider and a recipient. This, when there is a lack of hope, there is also bad health behavior. And when hope is promoted, we can see a good health outcome. Something good about it is that hope could be changed and could be measured. Next slide, please. If we are talking hope in general, let me here talk about hope for healthcare workers. As I shared, hope defined as interconnectedness, readiness for change, and future mindset. When there is a lack of hope, what happens is a lack of a sense of accomplishment, emotional exhaustion, and depersonalized, which is burnout. And that directly leads to poor quality of care, and healthcare workers are not resilient, especially from the literature that we've read. And when a hope is improved, there is no burnout. Burnout is prevented, and the quality care is improved. So we are starting a journey which is especially a research project to investigate and see how hope improved can increase the quality care in health services. Next, please. In this research journey, what we've done first, we validated a tool in our local language. Our local language is called Kinyarwanda. So we validated a tool that could measure hope. The tool was designed and created in US with US culture. So transculturally translated it in Kinyarwanda and our local language so that we could be able to measure hope improvement or decrease within our stakeholders. What we did next was to understand what is improving or decreasing hopefulness among healthcare workers and healthcare recipients that we are working with. The stage that we are currently in is to identify interventions that based upon what you've learned from healthcare workers and their recipients. Now we are identifying interventions and optimizing them so that we could, in the near future, engage with healthcare workers to see, to implement those interventions and see how they can increase the quality of care. Next, please. So as I was saying, what we did with understanding what is increasing hopefulness, we interviewed 242 frontline healthcare workers, pregnant and nursing mothers, policymakers, researchers, and line managers to understand what is really increasing or decreasing their hopefulness. In this slide, what you're seeing is themes that we collected from a qualitative survey that we have conducted from those 242 individuals that we interviewed. These are the themes that that are categorized in 3 sub-factors of hope. And as you can see, like trust comes in those 3 areas, but it has different meanings if we go deeper and define what trust means in terms of interconnectedness. What do they want or wish in terms of trust, but regarding to readiness for change, or what trust means in regards to future-oriented mindset. Next, please. Next, keep going. Okay. In this slide, sorry, it looks like, okay. Yeah, what you can see here is one part of hope, one in those 3 subcategories of hope, interconnectedness, and the themes we've learned from interconnectedness and their sub-themes. Those highlighted in blue are the sub-themes that we have realized that all resilient messages, if they are delivered as interventions, can respond to. Again, these sub-themes are information that we've learned from people that we interviewed when we were conducting qualitative assessment. So if I'm getting an example, like soft skills valued as of equal importance as technical skills, here healthcare workers are saying that they realized that having soft skills like communication, active learning, is important, like having other clinical technical skills when it comes to delivering the quality care. And that comes in what we call passion for all as a theme. And as for the resilient messages, there are so many. When they could act upon them, their soft skills could increase. So we realized that by implementing resilient messages, we will be responding to many of what our healthcare workers raised as challenges or gap in order to deliver quality care. Next, please. So what we did when it comes to resilient messages, testing them, we were lucky to be a part of this collaborating with the Dimagi, and we learned a lot from them. After learning from them, after participating in their meetings and learned how we could test all the resilient messages, what we did immediately was to translate them. We started with some of them, 10 of them. And then after learning what is happening, we then translated all of them in our local language in a way that we were understanding them, a direct translation without adding a tone or any tone or any other feedback from what we were hearing, because they wanted to hear everything from healthcare workers. So we created a working group so that we can be able to test the resilient messages. And once we get in with a working group, we brainstormed burnout and possible solutions. This is to help them because some of them, even most of them, they didn't participate in our survey. They could not understand why we want to introduce resilient messages. So we allowed them to, so we brainstormed, especially they told us what they think is burnout and what is causing them, and the impact is having, negative impact is having to their work. And then we introduced the messages and then tone, and then we recorded what they were discussing with us and telling us. And then we wrote them their feedback, wrote down their feedback so that we could change or adjust what they were telling us. Next, please. So as I was saying, we created a working group, technical working group. We created 2 technical working groups. When we first did the testing, we did only 10 messages. So we did it with a smaller group from Northern Province with healthcare workers that we have a strong relationship with, that we have been working with for many years. So those healthcare workers were frontline healthcare workers and their line managers. And the way we selected them, we first saw the healthcare workers who are experienced and who have a passion for their work. Then we saw healthcare workers that have been working with us, especially with our digital data solution program, who are participating a lot. And the third criteria was to see if a healthcare worker has a critical thinking, even though they have not been in work for many years, but they have this critical thinking when we are interacting with them. So for the first group, that was the criteria. And for the second group, the group we created, which was bigger and had many different individuals, we included, of course, healthcare providers, policymakers, line managers, and some advocate group, especially RNMU, which is Rwanda Nurse and Midwife Union, so that they can keep advocacy, because they have a lot of advocacy around resilience. Next, please. What we've learned when we asked about burnout, they told us many things which were similar to what we've learned from our qualitative survey, but what's also something new that they added for everywhere is that there is a burden from the supervisor, that their supervisor could be also one source of stressor or a source of burnout, the way they are communicating, the relationship between them. And supervisors here, the healthcare workers has many supervisors. They could be a person from an NGO. It could be a direct supervisor, could be a person from Ministry of Health. So what was concerning us was the relationship they had. So the consequences that they listed more often was a lack of passion to their work, and then sometimes losing even their job. They ended up quitting their job to go starting small business, or if the ones that are staying, they are providing poor quality of care. Next. So what we've used as a methodology is the methodology that Tanya shared, of first understanding the messages, and then asking the tone and voice, and then asking the questions for the explorative and then comparative as output data. So what we did was because all the messages were translated in our local languages and were recorded still in our local language, we gave them a paper printout. They read one message because we collected feedback one message by one message. So they were reading one message. We gave them 2 minutes to read a message, and then they were here to record from the same message, and then they will get 1 minute to provide feedback. So the first one was to test or to ask about the tone and voice, which we asked by how does the message makes you feel, who do you think the message is coming from, and how can we change the message? So it was strange for them when we started, because they were saying, I think the message is coming from this person, but when they get used, they were the ones to tell us how the tone should be, or which tone is better than the other, especially about the formal tone, which some could be a counselor and then a dialect person, a line manager, which they differentiated, and we didn't think about that. Next. So for the first group, when we started the testing, we get interesting feedback, and then we build from the first feedback to translate the rest of the messages. So then what they told us is that because in the first message, the first group, that's where also there are many introduction messages. So they told us that it would be better to engage leaders in the resilience program so that they can receive specific message to support their healthcare workers who are in the program of receiving messages. They also suggested that they could know in advance the days that the message will come, so that they could not be overwhelmed when they are seeing a message while they are working or while they are on their days off, but not expecting to see a message. Something new that they told us, really new, was that to remove some words, especially like this salary, because of legal concerns, because they were saying it will be accepting for getting paid poorly, and it was not something good they would like to see and accept it in their messages. In the second testing, also the message was they didn't give us many feedback different to the first group, but some of one of the main feedback they gave us was some words were really hard for them to understand, even a sentence really hard to understand, and we get losing tracking, like losing the original messages, because as they are already healthcare workers, they are used to providing some counseling. They wanted to frame a message in a way that they want, and sometimes losing the original meaning of the message. So they wanted to remove an entire sentence. And then we discussed how we can reframe that message in a way that could be understandable. And our moderators were informed about this and were conscious to make sure that the original message is kept, although there might be some changes around culture, around tones and voice, around using imperative word or engaging word instead of imperative intonation. Next, please. So in the big group, the third group, we really learned a lot from that group because we were with many individuals, and this is the group where we translated all of the message. And we had line managers, like directors of hospitals, people from psychiatric unity from Ministry of Health. We had different individuals, and they really gave us good feedback. But something we gained from them is that because we started with the first group in the northern province of Rwanda, so the translation was a bit skewed to that intonation or culture of North Province of Rwanda. So they gave us a feedback to make sure that it is reflecting the entire Rwandan culture, not one part of the culture. Something they really highly recommended was to screen burnout among healthcare workers before starting this, and they were engaged to participate in this screening of burnout, because when we were brainstorming about burnout, they realized that they need to know the number or even need to know more about it so that they can have a prevention around it. Next. Thank you. So our observation was there was high participation, especially the healthcare workers working from the ministry level and some directors. They said for the day that we translated all the messages, they were really with us. And when we asked them, they told us that it was the first time to hear a project that is working, or like their first concern is about healthcare workers, because healthcare workers' well-being, because they have been a part of many things that is improving the life of the recipient, but the healthcare workers as a main purpose was not usual. So we were really excited about that and happy for that. Another observation that we've seen is that they were acting upon, when they were reading a message, sometimes they were acting upon it. Like if they are discussing about a message of breathing, sometimes in a group, they will stop and then exercise so that they can give us more feedback. So we liked it. And also we have seen that they are changing behavior if these messages will be adopted. So they were worried that they might not be adopted, but something that they told us is that they need this awareness to be raised about, especially people from Ministry of Health. They say that it is a raising awareness, even though we might not see a direct change like in the near future, but a prevention is possible because they will be aware of what are the stressors and what they can do to act upon or to prevent them to have those stressors, especially stressors at work. So when also testing the message, we made some challenges, especially losing track of the original messages. This is because we were mainly working with healthcare workers, and they wanted to reflect what they want, if I can say, but not what is related to behavioral science techniques or like what was designed before. So we had to make sure that we really had that so that we don't lose our messages. So now we are at the stage of validating the messages, and then make sure that we will do also a back translation after validating the Kinyarwanda message. Next, please. So the lesson learned is that this is possible, that we can, once we are done, we will be able to implement this project, and the healthcare workers here in Rwanda are excited for it. And also we have been able to create a resilient working group that we can utilize or use them as visionaries to other healthcare workers they can facilitate or like pass the word about resilience and can facilitate the implementation, as we will keep working with that resilience working group for future projects. And as I said, also we'll be able to screen burnout and validate and do a back translation of our resilient messages. Thank you.
Thanks, Angel, for sharing these insights. We would firstly like to thank all the speakers for providing us with an overview of their organization and their vision, and also their learnings from the working group sessions. We would now like to open the floor for questions. And for this, I would request members to unmute themselves and share any insights or questions that they have for our speakers. Alternatively, you could also use the chat to post your questions. We did receive some questions on the chat before, and the first question that we have is a more general one that I would like to invite each of our speakers to respond to. The first question that we received is if the organizations can talk about the importance of resilience for the health workers that they support, and what are some of the key challenges that the health workers face? Would anyone want to go first and address the first question that we have?
Okay, Tanya, can you come again with the question? I didn't really get it.
Yes. So the first question that we have is, can you talk about the importance of resilience for the health workers that your organization supports? And what are some of the key challenges that the health workers face?
Okay. If you can hear me, let me just quickly for this. Okay, for us in AYGF, we were working with community health workers, and there are also frontline health workers in the community, giving various services to the beneficiaries on the field. So this is a very important program, a message that is intended towards building their resilience towards work, because here in Nigeria and the part of Nigeria where we are, we have a lot of challenges: security, banditry in particular, terrorism, and also social vices like low pay and remunerations for this health worker. So this is the right program for this set of individuals at this time. Because of course, when you have challenges like this, and then on top you're also a health worker administering, giving basic health business to people in the community, you need to also be motivated to do the work. So this is very key because it's also very important to this particular health worker. So again, some of the challenges in implementing this has to do with the issue of, like we mentioned earlier, scale up. Once you begin to bring in something new, others who might want to also be interested, and we're limited to just 20 health workers per pilot. So we've had that challenge, and also cooperation from the in charges, those that are in charge of the private health facilities that were intending to recruit and utilize their health workers. So this is also a challenge. Also, of course, for every new program, like, there are people that feel that there is a monetary benefit attached to it. And because of other programs that have also been in progress here. And so once they don't get that benefits, there's tendency for demotivation along. So these are key challenges that we are aware of and we intend to ride over. So generally, like I said, this program, the Resilient Message program, is very, very useful to the health worker at this point because of the situation we are in this part of the world. Thank you. And also, if Jeff can also make some comments and contribution. Thank you. And over.
Thank you, Joe, for sharing those insights. We have a question from Eckhard. Eckhard, I would request you to unmute yourself and you could post your questions to the group.
It'll be my pleasure. Thank you so much. That was a very thorough and interesting overview of developing messages for resilience. My questions, and my background is in research, so don't be surprised, is more about how do we know that our messages are effective? So we are doing our best to formulate the questions in an optimal way so it reaches the audience intended. But do we know whether they actually trigger change? And I think several of you mentioned changing the behavior of the health workers. I mean, when we talk about resilience, it's not just the destination, but it's really a journey. So we expect the health workers, after they hear the messages, to do certain things, whether it's engaging in self-awareness, in mindfulness exercises, breathing exercises, etc. But when you talked, I think, Job, in Nigeria, you talked about baseline, midline, end lines. Can we measure some of these things? Are we measuring what is the resilience level at the beginning of the messaging program, at the end of the outcome? Can we measure resilience building? We did some research and we haven't found really an accepted methodology that looks at resilience building and the kind of activities that we would want to see. So say a little bit more about it, whether you are planning on looking at some of these outcomes. Thank you so much.
Thanks, Eckhard, for the great question. We would like to invite organizations who are also implementing pilots to share some of their insights on the impact of the messages and how we plan to assess it. Yes, Paolo, please go ahead.
So this is a wonderful question. Eckhard, how do I say your name, please? Sorry. Yeah, all right. And also I would like to invite Chris to add. So this is a wonderful question. So we've been struggling to find a measure to measure resilience. That's the first difficulty, is to find a proxy or a measure that reflects resilience. And so at IHI, we use Juran's concept and also Churra's concept. We work with the run charts and control charts to measure, to answer the second question of the model for improvement, which is this change led to improvement? You know, because we need to know we've really improved the life of the workers. So we've been using run charts, you know, collected every month, and in everything that we do, we mark in the chart. You create a change was made this month here, and let's see what's happened with the run chart after the change. So the way that we know if the change was an improvement or not. So, and also we are designing a intervention with Dimagi to answer these questions. So we selected for example, for the 100 hospitals, we selected 5 measures, and we are gonna measure these along the way. And if I actually echoed to interact more with you and show what we've been doing in terms of measurement, because we try to be very rigorous about measurement, but I'd like to discuss more with you. So in the question about the app, the platform that we're gonna use for the 100 hospital, the Dimagi platform. And we have a study design that we're gonna run for 6 months to publish the results after the 6 months. Chris, would you add anything?
Sure. So the pilot study we are designing, it's randomized, non-blind, and what we will have 2 groups in the 1 unit of the participants. There will be hospitals and basic units or health, like primary care. So the pilot, 1 group will receive the messages, all the program through Dimagi app, and the other group will not. And through the app, there are measurements from baseline, midline, and end line, and also including a validated resilience scale, validated and transcultural adapted for Brazil. And they'll be done in the baseline, midline, and end line. Additionally to what Paulo said, I think this is the main design of the pilot study.
Thank you so much, Chris. We also have another question from Anne, and if you could unmute yourself and share your question with the group.
Sure, thank you. I'm Ann Cowper. I am a registered nurse who works with nurse managers in the United States using the resilience paradigm. Excuse me. So my first question is, what is the general, you mentioned 3-month time, and I'm not sure that was for everybody, but what is the length of time that you use for your projects to stay with the healthcare workers through the process? The second question was similar to Sabina's, I think, or was it, okay, well, the question is, what do you use as a baseline or definition for resilience? We use the resilience paradigm developed by Keith Blevins, and it comes through the 3 Principles community, which is an international community. Thank you for the opportunity. These have been some great insights from everyone.
I might jump in from Dimagi's side to answer. So the first question you had about the length of the program is a really good one, and I think the answer is still we don't know how long the program should be. The best guess right now is 6 months. So the pilots that will be conducted will be 6 months in length, and then we hope to get insights from health workers and implementing partners about whether that should be shortened or lengthened. And your second question about how we are measuring resilience. So as Paulo mentioned earlier, Dimagi has developed an application on CommCare, which is used to distribute these messages to health workers over the 6-month pilot period. And within that application, we have 2 validated measures that we're using. So one is a 6-item brief resilience scale, and the second is the WHO-5 Wellbeing Index. And the goal was to use validated measures which have the smallest burden possible on the health workers who will be interacting with the application. And that'll be collected at various points throughout the use of the application. Happy to tell you more afterwards too. Tanya and I can drop our IDs in the chat if people are interested in learning more about the application.
Thanks, Liliana. We have another question from Sabina, which I think to an extent our organizations have answered, but I will still go ahead and share this with the group. The first question is, on which platforms are the organizations planning to disseminate the messages? And the second question is, what are the plans to evaluate the impact of the messages?
Paulo or Chris, would one of you be willing to speak about the publication from IHI?
Yeah, sure. So we are going to use the Dimagi app. We're translating to Portuguese now. And for 6 months, we're going to send 3 messages every week. And then we're going to run a survey and collect data for 6 months, the baseline, middle line in the results. And that's what we're going to do. We selected 150 healthcare workers to apply this message. And what else? It's going to, Chris described the intervention already. What else? And yeah, we're going to use the Dimagi app. What else, Chris, we could add to this question?
I think you said it all. Yeah, we have 2 groups actually. We are going to compare the group receiving the message through the app and other group not receiving. We just be surveyed 3 times: baseline, midline, and end time. And Dubai.
Yes.
Sorry.
Mm-hmm.
Great. In the interest of time, we will move on, and I will hand this over to Jenny. In case there are more questions, we are happy to stay back at the end of the call and respond to any questions that the participants have. We will also drop our IDs, which team members can use to get in touch with us to know more about the working group and the adaptation process. Over to you, Jenny, for sharing the announcements from the Resilience Collaborative community.
Perfect. Thanks so much, Tanya. Just a quick few announcements, and thank you to all the speakers. It was just such a great session and so many interesting key takeaways. The last few things I just want to mention, if you haven't already, we would love for you to complete the Resilience Collaborative Evaluation Survey. We're trying to gather some feedback from members on your perceptions of the Resilience Collaborative and how we can make it better. So please consider taking that for us. You can scan the QR code, or Sarah will drop a link in the chat that you can visit to take the survey on Qualtrics. We also wanted to announce that we have a few new translations. Oh, sorry, my dog is yelping in the background. We have a few new translations that will be available for the resilience messages. Soon we will be sharing Spanish, Portuguese, and Hindi translations, so keep an eye out in the newsletter for updates here. Those will be shared shortly. And then finally, we are looking for a new host organization for the Resilience Collaborative. So if you think your organization might be interested in taking over the Resilience Collaborative and helping us achieve our goals and objectives, please consider applying. There's more information about the opportunity if you go to the link to read more about it. So please consider applying if you think you or your organization would be a good fit. QR code is is on the screen where you can just open up your camera and hold it over the QR code, which will take you to the link, or Sarah will also add a link into the chat. Also, we'll add email addresses to reach out for more if you have questions as well on any of these announcements or opportunities. Thank you so much.
Jenny, I have a question. When you mean host, what do you mean?
Yeah, so host meaning a secretariat of sorts, an organization. It could be one or even a couple of partnering organizations that are really the new home of the Resilience Collaborative. So someone that would be managing, taking over, you know, a community manager, and just facilitating the Resilience Collaborative is really what we're looking for. So rather than being housed exclusively through Johnson & Johnson, we're looking for a different organization to be able to house the Resilience Collaborative while meeting objectives of what we have already established for the Resilience Collaborative. There's a whole document, a proposal, a summary of the opportunity that's at the link. So if you open that, it might provide a bit more context as well. Also, if you want to connect offline too, happy to answer further questions on that as well. But hopefully that clarifies a bit more for you.
Yes, thank you very much. And I'd love to talk to you about it.
Awesome. Great.
Great.
Hello, everyone.
Sorry.
Okay.
Sorry, Joe, you had a question?
Yes,
Joe, I think you're muted.
okay. Can you hear me now?
Yes, we can hear you.
Okay, okay, great. Thank you, Jenny, for these announcements. And I will want to ask if this new host, the host you're talking about, the organization, the current organization participating in the working group session pilot program right now also qualified to also apply. So I just want to know so that we'll know how we can also be part of this.
Yeah, absolutely. So if you click on the link, which we actually sent out a link in the newsletter too. So if you've got the newsletter that went out on Tuesday, there was a link that's in the newsletter. And then I can also follow up with the email address of all the attendees as well. But absolutely, yeah, there's just the requirement for the application is really just looking for a good fit. We don't have, strict guidelines per se, but we just have, a set of 6 or 7 questions so we can learn more about the organization and the goals of the organization, and then just have more of a conversation, casual interview, not really interview, but just more of a conversation to make sure that the fit is right for the Resilience Collaborative. So if you are interested, make sure that you just fill out, answer some of those questions and fill out your information, and then the team will be reviewing the applications in the order that they're received, and then we'll be reaching out to have some calls with interested organizations. So we'll send out, make sure we blast out the information with links. Also be sure to check that newsletter because the link is in there. And then again, when we follow up with a recording of the session, we can also include the link for the evaluation survey as well as the interest in application for becoming the host organization.
All right, thank you so much.
Yeah, absolutely.
Thank you, everyone. With this, we conclude today's session. We would like to thank all the participants as well as the speakers. We would stay back for a couple of minutes in case there are any more questions, but thank you, everyone, for joining.
Thank you, Tanya. Thank you, Lillian, and everyone. Thank you.
Thank you, everyone.
Thank you.
Yes, Myra, I see a question from you. Would you want to share that?
Yeah. Well, we we had an interesting project last year working with health workers with, well, teaching them about self-care. So we would love to know when or how can we share our experience with you all, and when can we do this? Maybe in the next reunion.
That is a great question. And I think the Resilience Collaborative is the perfect platform for you to be able to share. Jenny or Sarah, one of you want to talk about the newsletter spotlights that you have?
Yeah, definitely. So our monthly newsletter that goes out, we have a spot for amplifying work of the members or spotlighting member work or individuals, doing work that's related in this area. We also even have spots for, if you have announcements or, wanting to look for opportunities for collaboration, we can send that out. The best way to do that would be either to email myself, which I just put in the chat. I'll also put a chat directly to the Resilience Collaborative that just goes to, all parties involved. But we can help you amplify any of those things or share resources that you have. We can add that into the newsletter. It goes out to, our member count is around 600 right now. So it goes out to about that many members. And we just ask, to let us know kind of your interest, and then we can work with you to, make it fit within our newsletter. And it typically goes out mid to end of month. The last one just went out this past Tuesday. So absolutely can send you my email as well as the Resilience Collaborative email so that we can connect on this and see how we can fit it within the newsletter.
Thank you.
Of course.
Jenny,
I see a question from Paolo. Oh, please go ahead, Paolo.
No, I opened the link and of course IHI is interested in, I have to have an internal conversation before I send the link. I send the application. So if I send the application now, it's just demonstrating that we are interested. And then you okay, so I do that, and then good.
Yeah, there's no commitment or anything yet until we make sure it's a good fit for all parties. So it's really just trying to garner interest, make sure that we have, similar goals and alignment, and just to show that, you have some passion and potential, drive to want to be able to be an organization that would be able to manage the Resilience Collaborative. So filling out the application doesn't commit you in any way, and we'll definitely reach out to have further conversations and whatnot. So, and you can take your time. There's the deadlines open. Of course, we're reviewing applications as they come in. So if it's something you need to take a couple days to internally have a chat about and fill it out next week, that's completely acceptable as well.
Okay. So, of course, the next question is there any funding, financial support to do this, or it's going to be volunteer work?
Yes. Yeah. So we have funding that's available. It's outlined in the summary document too, towards the end. So we do have funding to support this. Yeah.
Thank you very much.
Yes, of course. Thank you.
All right. Thank you, guys. It was
Thank you so much,
wonderful.
everyone. Have a good day.
Bye.
Thank you so much.
Bye.
Everyone, bye-bye.